Bueno, buenas tardes a todos. Muchas gracias por estar acompañándonos esta tarde en el webinar, en este interesante webinar que ha preparado Benedetto Yelpo, hablando de la apendicitis aguda. En estos momentos parecía que todos lo sabíamos todo, que había un tratamiento que eran 4 líneas de cualquier texto, cualquier libro de texto, pero de pronto nos lo han cambiado, y ya no está tan claro que el tratamiento de elección, el gol estándar, sea la apendicectomía sin más. O sea, con lo cual de eso va a tratar el webinar de hoy y lo moderará Benedetto Yelpo. Ya me han dicho que Salomone de Isaberio no estará con nosotros y Gianluca supongo que se conectará en algún momento a lo largo de la tarde. O sea que muchas gracias a todos por estar aquí y Benedetto, es tu momento.
So therefore, if you don't mind, we switch just in English language, because as you see, this is an international conference. So really, dear friends and colleagues, welcome back to this new American College of Surgeons Spain chapter meeting. You know, this is the last one of the season before the summer. So we will be back in September, hopefully. So today the format is a little bit different because we have some international guests to speak about a very controversial topic, as Luis Grande said, so acute appendicitis. So let's welcome Mauro Podda and Francesco Pata. They are Italian good friends and colleagues as well. They are Italian, so Mauro is working in Cagliari and Francesco Pata in Rende. And really we count on these two surgeons, which are really the leader on this topic, because they participated. They literate the guidelines of the treatment of acute appendicitis. So I think that they are the best person to tell us which are the last controversies and the update, the new treatment on the acute appendicitis. So if you don't mind, Mauro Podda, you're the first, so you can start your presentation.
Thank you, Benedetto, and let me thank also the American College of Surgeons Spanish chapter for this great opportunity to join this webinar and to join a full group of friends of mine. I try to share my screen. So we are going to talk about acute appendicitis. Sorry. Okay. I have no conflicts of interest regarding this lecture. I don't know if having participated to the guidelines may represent a conflict of interest, but I hope no. And in brief summary, what are we going to talk about during this webinar? The first question is, why should we find a different treatment beyond appendectomy? Because we know that, as our colleagues say, it is the treatment of choice for acute appendicitis, which is mostly related to the more holistic question, which is why we have the appendix. And we will see now evidences and perspectives. How to diagnose an acute appendicitis, which is not always easy. And it's probably the most outcome impacting step of a correct approach to acute appendicitis. We will see if antibiotics are still necessary for the conservative treatment of complicated forms. And we're going to talk about if endoscopists are stealing us the job, which is the main topic of the talk by Francesco Pata. And we try to find something new and try to navigate in the evidence for future studies. So apparently, we have a winner in the run of treatment of acute appendicitis, because all the guidelines since 20 years ago confirmed that acute appendicitis, laparoscopic appendectomy is the treatment of choice for acute appendicitis. It has been remarked in Jerusalem guidelines, the update of the Jerusalem guidelines, the EAS guidelines. So it's probably one of the few treatment and diseases where we have a real gold standard of treatment. So appendectomy is considered the standard of treatment for acute appendicitis. So However, if we have a look at potential complications of this, we can say easy laparoscopic operation, we know that there is also some risk of complication. About 6–7% of patients after an appendectomy have a surgical site infection. There is the risk to conversion to open surgery. There is the risk of bleeding, organ and vessel injury, potential risk associated with adverse reaction to anesthesia, pain, discomfort, ILS, pneumonia, and DVT and PE. But above all, there is again the risk of a negative appendectomy rate, and this risk is up to 28% in some international series. From a more holistic view, we can also say that if God created us with an appendix, this appendix obviously may serve some purpose, and we are approaching the studies, more and more studies that assess the role of the appendix in the development of a good microbiome, and how the appendectomy can be associated with the risk of colorectal cancer. So if we have a step back to the beginning of this new debate about antibiotic strategies for the treatment of acute appendicitis, we can consider this editorial by David Flum, published in the New England Journal of Medicine in May 2015, as the start of a new debate about antibiotics for the cure of acute appendicitis. But if we have a look at earlier publication, we can see that already at the end of the 19th century, there was a study, this one by Reginald Fitz, who talked about potential potential conservative treatment of acute appendicitis. Antibiotics were not available yet. And again, in the middle of the 19th century, this publication by Harrison, and later on this one by Caldry, remarked the role of conservative treatment with antibiotics for acute appendicitis. But I think I would say the most smart paper that tried to explain us how the natural story of acute appendicitis developed for a complicated case is this one by Roland Anderson, published in 2007 on the World Journal of Surgery. Roland Anderson, which is one of the most relevant scientists in the field of acute appendicitis, showed us in a very elegant way how uncomplicated acute appendicitis resolves spontaneously in most cases. And another relevant aspect that was demonstrated in this systematic review by Roland was that when we have a perforation, this perforation of the appendix takes place in the pre-hospital phase, probably during the first hours from the rising of acute appendicitis. So hospital delay for a more accurate diagnosis, with a CT scan, does not impact on the risk of perforation of acute appendicitis. So as a final remark, Roland Anderson stated that for acute appendicitis, a precise diagnosis, which can distinguish between uncomplicated and complicated forms, is more important for therapeutic purposes than an early diagnosis. Regarding conservative treatment with antibiotics, the Jerusalem Guidelines, the first edition in 2016 by Salomone Di Saverio, were the first to suggest that it might be room for conservative treatment with antibiotics. And in the update of 2020 of the same Jerusalem guidelines, we remarked with the suggested all surgeons approaching acute appendicitis and complicated forms of acute appendicitis to talk with the patient about potential strategies, including antibiotic first strategies. So a more involvement of the patient in her or his process of cure was suggested. In the same period, we published with this meta-analysis in Annals of Surgery that showed that antibiotics first strategies for uncomplicated cases of acute appendicitis may fail in about 8% of cases, with an additional 20% of patients that might need a second hospitalization for a recurrence in the first year from the index admission. However, what was missing in that period, in those years, were the results of long-term follow-up and a sort of investigation about a tailored strategy for each patient. So we could not distinguish in that year which patient should be excluded from conservative treatment. The answer to the first question came a couple of months later. We published that meta-analysis with the follow-up at 5 years of the APAC trial by Paulina Solminen, that showed that at 5 years follow-up, the risk of recurrence of an acute appendicitis in an uncomplicated form was about 39%. And you see that most of these patients recurred with an uncomplicated form again, so not with more advanced stages of acute appendicitis. The vast majority of these patients recurred during the first 2 years. The second question, it's probably still debated. So how can we select patients who might respond well to antibiotics and exclude from conservative treatment those patients who might not? The first papers that tried to assess this aspect were published in 2014, such as this by Jeanette Hanson, who found that with a CRP lower than 60, with a white blood cell count lower than 2,000 and an age lower than 60 years, the success rate of conservative treatment was about 90%. We also tried to assess this aspect. However, in our study, we excluded patients with an appendicolate, so we were not able to find any other risk of failure for conservative treatment. And later again, this paper by Loftus showed that the duration over 24 hours of the symptoms, the modified Alvarado score lower than 4, and an appendiceal diameter lower than 13 millimeters were associated with a successful treatment, non-conservative treatment. But I think the most important result about this patient-tailored strategy came a couple of years ago by the CODA trial, which demonstrated, the CODA is a randomized controlled trial that compared the conservative treatment with antibiotics and appendectomy, concluded that only the presence of an appendicolate, so a fecalate, inside the appendix can be considered a risk factor for failure of conservative treatment with antibiotics. This finding pairs with another important aspect, which is this one regarding pathology. I mean, if we look at a patient with appendix, with an appendicolate inside the appendix, even if this patient are not perforated, have not a perforated disease, but the presence of an appendiculate during an appendicitis is related to a complicated form because modifications and damage to the mucosal layer and the diameter is more significant of a complicated form with an imminent perforation than an uncomplicated form. So nowadays we must consider patient with acute appendicitis and an appendiculate as patient with a complicated form of acute appendicitis, and this patient must be excluded from conservative treatment with antibiotics. And this can be also related to a new research finding that showed us that patients with uncomplicated cases differ in the composition of the intestinal and appendiceal microbiome from those patients with complicated cases. So in other terms, in other words, we must consider uncomplicated forms of acute appendicitis a totally different disease from complicated acute appendicitis. What if we exclude appendiculates, patient with appendiculates from this analysis of risk factors for failure of non-operative treatment with antibiotics? You can see that there are a couple of other variables that are associated with the risk of failure, and these are body temperature over 38 degrees Celsius and an appendiceal diameter over 15 millimeters. I think we are approaching the beginning of a new era in the treatment of acute appendicitis because there are already 2 randomized controlled trials, including patients with uncomplicated forms of acute appendicitis, which showed that if we have a patient with an acute and complicated appendicitis and we treat this patient with antibiotics or only with painkillers and control of symptoms, fever and pain, the result is the same. So patients who are going to be cured with antibiotics for uncomplicated appendicitis without appendiculates may probably resolve even without antibiotics. And in the era of antibiotic resistance, superbugs and other problems associated with overuse of antibiotics, I think this is a very important finding. Regarding the diagnosis, we all know that we have a gray area regarding the diagnosis, which is the intermediate classes of the I-score and the adult appendicitis score. In our guidelines, we suggested for our patients with failing to the intermediate class to undergo for a systematic imaging. And this imaging now can be considered the low-dose protocol CT scan. However, 2 years ago, the group by Ari Lepaniemi published the result of the Diamond trial. In a few words, the Diamond trial randomized patients in an intermediate risk of acute appendicitis score to imaging with a step-up ultrasound CT scan approach, and observation and repetition of the assessment with a score after 6 and 8 hours. If the patient who underwent imaging were confirmed with an acute appendicitis, that they underwent lap epi. If the patient submitted to simple observation after 6 or 8 hours had an unchanged acute appendicitis score, underwent imaging. If they had an increased acute appendicitis score, they underwent appendectomy. And the results are that patients who underwent a simple observation and repetition of the acute appendicitis score after 6-8 hours had a lower risk of undergo an appendectomy. So we should maybe reassess that statement about intermediate class with the possibility to offer this patient also a short period of observation in our surgical wards. About endoscopic treatment of acute appendicitis, I will leave room to Francesco Pata, who is going to talk about ERAT more in depth. You should just know that at the moment we don't know where to put ERAT in the line between conservative treatment and laparoscopic appendectomy. So we see news from Francesco. And in the meantime, we were doing some philosophy about how to treat acute appendicitis. It came COVID-19, which in my opinion is the real life trial, the most relevant and most numerous and EV real life trial. In the same period, we did a lot of research with my friends Benedetto, Gianluca, Francesco, and Salomon, and many others. And we found that people started to treat patients with uncomplicated appendicitis with antibiotics. And I think they were comfortable to treat this patient with antibiotics because they already read the research about conservative treatment with antibiotics. Again, we can note that while we were experiencing a lower and lower incidence of uncomplicated appendicitis, at the same time, complicated appendicitis form raised and raised the treatment with antibiotics without increasing of non-operative treatment failure. And again, Roland Anderson gave an elegant explanation of this phenomenon, and is with another systematic review. And he stated that we were not experiencing disappearing acute appendicitis. Uncomplicated appendicitis were not disappearing. But patients had the problem solved at home because they did not refer to hospitals because of fear of COVID-19 in that period. And at the same time, Roland Anderson demonstrated that there was not an increase in complicated appendicitis per se, as a total number, but we were experiencing that increasing rate just because we were not seeing uncomplicated appendicitis in our hospitals anymore. And this is the lesson we should bring to the future from COVID-19. Another relevant aspect, in my opinion, is that involvement of our patient in our research. Just see this paper published last year in the British Journal of Surgery by the group, the Amsterdam group by Maria Burmeister. Just if I remember well, 10 years before, a paper came in the Journal of Trauma and Emergency Surgery with the potential choice by people with an acute appendicitis regarding the treatment. And in that occasion, people ignore and were not keen to undergo conservative treatment with antibiotics. After 10 years, probably because antibiotics are a mainstream issue for acute and complicated appendicitis, but half of the patients interviewed in this paper for this study may prefer antibiotics for the treatment of uncomplicated appendicitis. And they are keen to accept the risk of failure and the risk of recurrence. So we must take into account patient's opinion and patient perspective in our modern ways of treatment of acute appendicitis. Another aspect we can't ignore anymore is the help of artificial intelligence in the diagnosis and predicting models for acute appendicitis. And efforts of studies and the efforts of research are now focusing in the elaboration, in the building of machine learning models for the prediction of complicated forms of acute appendicitis, which are important for the treatment decision making, and the definition of outcomes of acute appendicitis. So I think artificial intelligence will give us much help and more help in the future. Thank you. I've concluded. I will be happy to join any discussion and answer any question we can from the audience. Thank you.
Thank you very much, Mauro, for a real terrific presentation. You give us really a very good controversies update on the treatment, conservative treatment of appendicitis. Let's also introduce two of my colleagues and friends, which are going to also to participate later after Francesco Pata conference to some questions, which are Salomone Di Saverio. We nominated him quite a lot in this conference for all these papers, participation in the guideline from Italy, from San Benedetto, and then Gianluca Pellino, an Italian surgeon from Barcelona, which is going to make some discussion later on. Okay, so Francesco, now it's your turn. So I want to know if there is any room for the endoscopist instead of the surgeon. Should we ask endoscopy to treat the appendicitis or not?
Okay, thank you, Benedetto. I want to thank the Spanish chapter of the American College of Surgeons for this opportunity. I will provide you an overview of this relatively new endoscopy treatment for acute appendicitis. What is IRAT? IRAT is an endoscopic retrograde appendicitis therapy. It's a therapy that was first described in literature in 2012, but the first case was performed in December 2009. At the moment, we have 5 articles published in English from China. This is the research I did yesterday about this topic. And if we look at the type of publication, we have a lot of case report, editorial, technical note, but there are some observational studies and also 3 randomized control trials. But the perception that we have here from the developed countries is quite different from China, because if you look at this narrative review from China, we see that more than 10,000 patients have been already undergone to IRAT in China in more than 150 hospitals and in 33 provinces. So why for now the IRAT is a quite new and innovative approach to appendicitis is already an established treatment in China, and this should be taken account when we evaluate this procedure. I want to thank Dr. Bahong Yang to give me the opportunity to present this video that summarizes the most important steps of IRAT procedure. The procedure is performed in position by a normal endoscope provided by a transparent cap with the tapered shape just to push aside the Gerlach valve and to help the visualization of appendiceal orifice. Then the appendix is intubated by a guide wire technique and is performed in a similar way of an ERCP, the appendiceal lumen, to show the morphology of the lumen if there are some stenosis defects like fecalids. And as you can see, after the introduction of the tube, the appendicography, the pus is pushed away thanks to some flushing with saline solution. This is very important to start the removal of any stenosis inside the appendiceal lumen. Then this flushing can also help to remove some fecalids inside the lumen of appendix. This is described as quite simple endoscopy procedure for skilled endoscopists. As you can see, there is several attempts to flush the appendiceal lumen just to relieve any obstruction, and then it's possible also to remove the fecalids by a basket, by the dormal basket, and the fecalid can also come out by itself thanks to the flushing and aspiration by the colonoscopy tube. So this quite standard procedure, similar to the ERCP, but there are no sphincterotomy, obviously, so less risk of complication. At the end of the procedure is performed the appendicography to show the successful procedure. And in many cases, above all when there is some stenosis in the lumen, a stent is placed for 1, 2, 4 weeks to gain the more advantages of this approach. So after 2 or 4 weeks, the stent can be removed after CT scan on X-ray of the abdomen, but in some cases this can be eliminated spontaneously by the feces. So this is very important because we have some cases reported in the literature of perforation due to a stent that was not removed some weeks after the procedure. This is a shorter video that's showing us IRAT has been not only used for uncomplicated appendicitis, but also for complicated appendicitis when there is just a small periappendiceal abscess. As you can see, in this case, the mucosa of the cecum is inflamed, so the or appendiceal orifice can be quite tricky challenges. Comparing with the previous video, the identifying of orifice of the appendix is difficult. You see, the endoscopy needs more practice to perform this procedure in this kind of complicated appendicitis. Basically, after the finding of the orifice of the appendix, that is one of the most difficult steps in this phase. You can see now, you see a bit of pus already discharging from the appendiceal orifice. There is an intubation by a guide wire catheter technique of the appendiceal lumen. And just with the insertion of the catheter, you see a lot of pus coming from the appendix, showing a successful intubation. After this part that can be implemented by several flushing by saline solution, the steps basically are the same with appendicoplasty and after some retrieval of fecalids if present with the plastic stent removed. So it's quite a standardized technique at the moment. Basically, we have now 2 variants of the main procedure. That is one that uses a ultrasound for children to avoid X-ray exposure, and also IRAT with the use of cholangioscope to incannulate the appendix and to remove under vision fecalids and other problems as been also described. So we are in China, they are moving to further implements of the technique, considering that they are applying it quite extensively in the population. So with the aim to do a review of the literature and to perform a meta-analysis, we decided to do this systematic review the last years with Mauro Podda and Doris' colleague. As you can see, 2 systematic reviews were already performed, but the comparison with IRAT versus antibiotic was not present. Some studies lacking because were not published at the time, and we use also the GRADE methodology about to perform a quality assessment. So with this aim, we perform this systematic review. These are the main features of the systematic review. We consider all English literature from 2012 to April 2023. We use we included both comparative, retrospective, or prospective studies and a randomized control trial. This could be a potential drawback of the systematic review, but there were not so many evidence to get a definitive conclusion about IRAD. So we decided to include both, and then we use Cochrane tools to evaluate the risk of bias that was qualified as low or moderate, and we evaluate the quality of the literature also by graded approach. We consider as primary outcomes technical success and treatment efficacy at 1 year follow-up, and as secondary outcomes the post-intervention pain, the procedural duration, the length of hospital stays, the complication, and the recurrence. What we observe using the great quality of evidence assessment, basically that some outcomes that we considered, such as admission, length of hospital stays, short-term complications, treatment efficacy, were qualified as low and very low, and the same when we compare IRAD and antibiotics. At the end of our research, we selected 6 studies, 4 comparing IRAD with surgery, appendicectomy, both open and laparoscopic, 2 comparing IRAD with antibiotics. These are the first plots that we use to summarize our findings. Basically, when we consider the 4 studies that compared IRAD versus appendicectomy, we see that IRAD have taken some advantages about 2 features, that was the 2 outcomes, the procedural time and the post-intervention abdominal pain. But when we did a subgroup analysis comparing IRAD with laparoscopic appendicectomy, the advantage about post-intervention abdominal pain disappeared. So the only procedural time was kept, and this is an obvious results. The appendicectomy had some advantages about the recurrence at 1 year follow-up. What about antibiotics? Basically, the result were similar, but we had an advantage in the IRAD group about post-intervention abdominal pain and also post-intervention duration of clinical symptoms. We also observe a reduced length of hospital stays in the IRAD group. So the overall results shows that IRAD, in comparison with surgery, showed some advantages in procedural duration, post-intervention pain, but just when compared with open surgery and hospital stays. Obviously, there is a higher risk of recurrence compared to appendicectomy. About antibiotics, we can see that that can be considered as a potential alternative to antibiotics. As Mauro Pod said before, the presence of fecalids, appendicolith, is a predictive factor of failure of antibiotics treatment. With IRAD, we can treat this group of patients, removing in active way the stones inside the appendicitis. And so a potential indication could be in the future the treatment of this kind of patients that are classified as uncomplicated appendicitis, but they preserve some additional feature in regarding of the antibiotics treatment. So these are the conclusion, but we need to consider some limitation. First of all, many of these studies use small sample size, and so there was an high heterogeneity in outcomes. There is also an high risk of imprecision due to the grade assessment of some of these outcomes that were classified as low or very low. And one other problem is that all the studies we analyzed were from China. So this procedure has been performed in a system with a different healthcare organization, different facilities, different healthcare resources. So it's quite tricky to generalize these results to all countries. This is one of the main drawbacks of the systematic review we performed without IRAD. So what we can say that IRAD is a promising intervention because it has been already tested several ways in China with some positive feature regarding the organ preservation in the light of future research showing some advantages in keeping the appendix, and can have also some advantages in terms of fast recovery after the procedure in comparison with surgery. We need to consider that we need more and more solid evidence to do a definitive statement about the ERAT in the clinical practice. So at least in the Western countries, we should consider this probably in controlled trials before do a definitive recommendation. So we have the promising results. The techniques is extensively performed in China, but we need more and more evidence to generalize this result in the current clinical practice. And with this, I well, thank you. And these are some articles we already wrote in the last year about the topic of appendicitis with Mauro Podda, Benedetto, and other colleagues that are very focused on the acute appendicitis treatment. Thank you.
Thank you very much, Francesco. Really interesting. So if you can just stop sharing. Also, all these authors, most of these authors are here in this webinar. so please take advantage of all of these authors here in present. So I only very quick question, and then I will leave also to Salomone and Gianluca if they want to make any comment or question. My question is very easy. Are you aware that this technique had been already used here in the Western world, or is still only in the limited to the Eastern world? Because it had been performed in, if I understood well, in 10,000 persons, no, in the Eastern. Do you know if any surgeon or endoscopist already did that procedure here in Europe or in the United States?
Not at the moment. At the moment, the procedure is quite country specific. We have only contribution from Western country in the light of editorials or opinions. Probably the further step should be to try to introduce this technique in the European or Western countries. So it's very difficult to introduce because we need to consider some problem related to the organization of healthcare. So having an endoscopy ready to perform this procedure, having a volume adequate to standardize this procedure can be the first obstacle to perform this operation in one of our hospitals. So probably the future will give us some suggestion about this. I think that with the last improvement related to the use of a cholangioscope or ultrasound, we can reduce some criticism related to the X-ray exposition. But at the moment, I think that it is very difficult to introduce this treatment in our current pattern of practice in the Western countries.
Yes, also maybe I think in practice still young procedures, maybe just give some few years just to see if there is any further indication. I think that there will be some rooms here in Europe. I don't know, what do you think, Salomone and Gianluca? Do you think that we should try to...
I have a question for Francesco. So thinking about barriers, if there is any other barrier that you can identify, and if we are to start this procedure, on which patients would it be better suited to begin with?
Yeah, very interesting question, because we need to balance the potential advantages and the potential risk of this procedure. In China, they describe the ERAT also for high-risk patients, for example, in pregnant patient in the first trimester, or in patient with a recent myocardial infarction. But I think that your question is, the first topic to be focused. Which patient should be the first target of ERAT in Western country? Because the Chinese authors perform the procedures in adult patient, in children, reporting good result. Probably for ethics problems, I think that the target population could be adult patient refusing surgery as a first step procedure. This could be a potential population as the first, population of a trial in Western country for ethics reasons.
Mauro, do you want to say something?
Yeah, giving a step back to what you asked before, so if there is any experience in Western countries with ERAT. At the moment, Bao Hong Yang, which is already a friend of us and collaborates with us for some study, and his chief, which is Professor Liu, who is the mentor of Bao Hong and the person who invented ERAT, are bringing endoscopists from Europe to China to be trained in ERAT. But what I'm trying to explain to Bao Hong is that there is no room for ERAT in uncomplicated cases, because uncomplicated cases, which is the large amount of studies are focused on uncomplicated cases, solve spontaneously in the vast majority of cases. So what they should focus on is complicated cases with fecalids and also periappendicular abscesses. Because if ERAT is able to drain inside the appendix an abscess, that patient can spare of impacting surgical intervention. You know that a great part of patient with appendiceal abscess and the operation with a right hemi or an ileocecal resection. It's not so simple to operate on patient with appendiceal abscesses. So I think the main room for improvement of ERAT are complicated cases. So I suggest them to leave uncomplicated cases to solve by themselves and focus on complicated cases.
Yeah, in fact, I want to ask Francesco about all these cases from China. There are how many of those have been treated with ERAT and then with antibiotics as well?
Well, in our meta-analysis, we had two studies comparing ERAT with antibiotics. One was focused on adult population between 18 and 65 years old, and one other was in children with a modified ERAT approach using ultrasound instead of the X-rays. But because there were only two studies, I mean, it was quite difficult to do definitive statement of the superiority or not of the two approaches. We need more better designed study on this topic. So yes, the Chinese performed a lot of studies, but we need the more better designed one studies.
But most of those studies were of patients with ERAT were treated without any antibiotics, zero antibiotics, directly with ERAT.
Yes, all in case of periappendicular abscess, they suggest a short course of antibiotics.
Yeah, okay.
Again, we need to decide what is the best target in this case. Probably I agree with Mauro about the presence of fecal. It has already told you in my presentation that could be a potential target of ERAT.
Yes, also we have to remind that for all this treatment, we need even a better definition of uncompleted appendicitis, and we need a CT scan. So all these patients that right now we are performing surgery after ultrasonography, which is something very, very not controversial, but it's something which is really established in the last years. But we have to go further with these patients with CT scan. Yes, Mauro.
Yes, it was controversial when Salomon and me tried to write this statement in the Jerusalem Guidelines 2020 edition, where there was a huge debate about the step-up approach with the ultrasound and CT scan or straightforward for a CT scan. I think we are now moving for a straightforward CT scan for this patient with intermediate and high adult appendicitis score or AIR score with that protocol I showed you before, so the low dose CT scan protocol.
Yes, Gianluca.
So I think to convince Western country authors about the safety and reliability of the procedure, because not everyone knows the authors. We need to take a step back here, because the procedure was started and divulgated without complying, for example, with the ideal framework for innovations in surgery. So I think if the proposer of the procedure are to disseminate it and are interested in that, maybe they should think about reframing the process of how it was started and complying with some basic recommendations that we now have for innovations in surgery. That could be something to consider as well.
In fact, the main aim of this webinar is just to make surgeons be aware, about all these alternatives, and also to reflect about that, because maybe there is always room for innovation, and maybe there is also some indication about those cases. For instance, I want to ask to Salomone if imagine a cases in urgency with an acute appendicitis. I imagine that is uncomplicated, but it's a patient, for instance, with a carcinomatosis, or a patient which is not fit for surgery, and maybe antibiotics is not working very well. So do you think that we should think, for instance, for such cases, there's any room for ERAT? What do you think, Salomone? It might be a case, I mean, it's not very common, but in those cases where there is no chance for surgery, high risk, really very high risk, do you think that there is any room for ERAT in those cases or not?
If it is you mean a frail patient?
Yes, very frail patients, whatever, any reason to make the surgery with really, really very high risk.
Yes, I agree with you. Perhaps the only, I mean, I may be, I may be old-fashioned now, but I don't know. I can't see the real. Also, balancing the cost and benefits. You know, how much does it cost a stent, or I mean, but probably, as you say, the best indication is patients, as Mauro said, with complicated appendicitis. They cannot as an alternative to non-operative management or percutaneous drainage.
Yes.
Whenever they cannot undergo general anesthesia.
Yeah. Always take in mind that this is still a very young procedure. I mean, just imagine that right now endoscopies are really going very, very fast. Right now, they make also some hepaticoionostomy in a minimal invasive way, radiologists, and also they drain very big abscess in the pancreas through the stomach. There might be also room also for this for the endoscopist. And so we just have to be aware about that this is still a very young procedures, and maybe there are some indication. I don't know. Fernando and Luis, can I ask you, are you afraid or not about this? Because I see you somehow struggling in this about these procedures.
I think it's not a real position between Eastern and Western countries. It's not a real situation. I think in this moment is a real problem for any emergency in Spain, for example. It's not possible. The loyals are against these movements. And in any way, these procedures may be done by a surgeon, not by endoscopists.
Yes, good point.
And those of us who have reached a certain age have seen many techniques introduced throughout our lives. And a few have remained, and many others have fallen into the emptiness. No? And frankly, it's difficult for me to think that ERAT is a procedure that is here to stay. Obviously, it is more expensive than antibiotics, it requires a team of trained and interested endoscopists, and this is a key point. And obviously, the surgical alternative, you pay a price. I'm not saying it isn't, but seems more consistent with the current data, more consistent than the ERAT. But obviously, maybe in some specific cases or in some specific moments, ERAT could be an alternative. But I think there is no so much place in Western countries to the ERAT. This is my opinion.
Yes, you're completely right. Maybe it is not a substitute, just an alternative. So in some specific case, very rare, maybe very few cases, we should be aware about this. Do you agree, Mauro?
Can I say something? In my personal view, it all depends on how much relevant is for us the option to spare an appendix. Because if studies on microbiome association between appendectomy and rising colon cancer and rising cardiovascular diseases, rising strokes will be more and more convincing. I don't think it's a problem of a technique. I don't think it's a problem of the environment or the awareness of a system to perform an endoscopic procedure. I think it will be a problem of our mind, and it relies on how much we are convinced about the fact that sparing an appendix is important. We don't have, I would say, we don't have a strong evidence on the role of appendix and microbiome and the other diseases I listed before. But if and when this evidence will be stronger, I would think we will watch these new techniques in another way.
Yeah, completely right. So just be aware about these two controversial approach, that of antibiotics, conservative, and the mild conservative, that of ERAT. We shouldn't never be so dogmatic. Just be waiting and see what is going on. Few cases, really, even if they stated there are 10,000 in the Eastern world, but we will see what is going on. Reminded all these data, they belong from China, which is not very easy to access to the real data. Quick question to Mauro, if you don't mind. Okay.
Yeah, right.
We'd like to know if you know which is, I mean, it's very difficult to know, but which is your sensation? What do you think about the adherences of this protocol here in Europe? I mean, do you know, to the better your knowledge, there is any center which is really using antibiotics for the uncompleted appendicitis or not? What do you think?
Yeah, I think is a treatment which is having a good spread all over Europe, especially after COVID-19. What I can find is not already standardized in a proper way is the stratification of patients to whom we can suggest or only propose and try to explain the chances for a conservative treatment. I see many colleagues around the world who join us for some talk that are not aware about the relevance of the presence of an appendiculate inside the appendix. So they are not aware about the fact that patients with an appendiculate can't be treated with antibiotics because they already have a gangrenous form and they are going to develop a perforation.
Yes.
I think that's the most important thing. We should remark that patients with appendiculates have a complicated form from the beginning.
Yes, it will be very interesting to make something like a survey just to see which is the adherence of this type of treatment all over the world. I mean, how many centers are doing this? And of course, I think that all these are out from any type of trial, out of any other type of study. So
The
still
other,
very controversial.
The other thing which I think is very, very important is the perspective that maybe we are going to consider an uncomplicated form of acute appendicitis very next to an uncomplicated form of diverticular disease at that moment. An uncomplicated form of acute diverticulitis. And similar with what we are doing with acute diverticulitis without perforation or abscess, I mean, we are not going to give antibiotics anymore to this patient. I think we are next to do the same thing with acute appendicitis. Uncomplicated forms.
But really, I want to thank you all of you for this webinar. I just asked Luis just to say something just to close this meeting. I remind you that this is the last one of the season of the American College of Surgeons organized by the Spain chapter. So we will be back again on September with the new webinars, and we will also try to ask for some credits for this online type of meeting. I don't like the word webinar. Better online meeting. Okay, so Luis, your turn just to close the meeting, if you don't mind.
Okay, many thanks for this fantastic webinar. It was the closing seminar for this year of this course, and thank you very much to Benedetto, to Mauro, to Francesco, Gianluca, and Salomone. Thank you very much for staying this afternoon with us, and we wish good vacations, good holidays during the summer, and see you all of us in September. Thank you very much for sharing with us your experience in this simple but quite complicated topic. Thank you very much.
Thank you for the kind invitation.
Thank you. Thank you, Professor.
Bye.
Thank you, Benedetto. Bye.
Bye bye.
Ciao a tutti.